This is going to be Chapter 5, Blood and Blood Products. Introduction. It is becoming more and more common for EMS professionals to give and or transport patients who are being administered blood or blood products. It is important to have a solid understanding on the blood forms that can be administered, the therapeutic results expected, and the side effects administering these products can create. Adverse reactions and side effects of the cardiovascular system can occur while administering blood products, including chest pain, hypotension, and arrhythmias. Basic immunology. First thing we're going to talk about here, and these are some terms, is going to be immunity, a condition in which the person is protected from disease. Second thing we're going to talk about is an immune response, the ability of the immune system to respond to foreign invaders. Antigen, an agent that combines with an antibody to elicit an immune response. And we talked about this in A&P, is called an antigen-antibody reaction. An antibody is an immunoglobulin. An antibody develops in response to an antigen that enters the body and combines with it. Basic immunohematology, my apologies. We're going to talk about red blood cells, blood groups, and Rh factor. In red blood cells, the erythrocytes have an important protein on them called hemoglobin. Hemoglobin is responsible for carrying oxygen and carbon dioxide. An isoantigen is a substance that can stimulate the production of antibodies when introduced into the body. Blood groups. Every person has two genotypes that decide their blood type, and the genotypes come from mother and father, and they're going to be things that you would run a Punnett square on to determine what actual blood type the person has. Every person has two genotypes that decide their blood type. These pairs are what determine one of four blood types, A, B, AB, or O. Rh factor. RhD is an antigen, is a component of the Rh blood group. When a person has the Rh factor on the surface of their red blood cells, they are Rh positive. When the Rh factor is not on the surface of the person's blood, then they are Rh negative. An Rh positive person can receive positive or negative blood, Rh negative blood. A person with Rh negative blood can only receive Rh negative blood. Now, why this is if you are Rh negative, you have not been exposed to the Rh positive antigen, and you will build antibodies. You could have a hemolytic response at the worst. Blood typing and cross-matching. Blood typing is a test that's run to determine the patient's blood type. And cross-matching is the process that determines the compatibility between blood donor and the patient or the recipient. Agglutination is what they kind of look for, is clumping of the particles. The word agglutination comes from the Latin word meaning to glue. ABO blood typing. So whenever we talk about blood typing, and we're talking about A, group A, these little things right here are the actual antigen. And the antigen identifies group A blood or A-type blood as I am A-type blood. So that's what those antigens are there for, is to identify it. Now, the antibodies that are present in type A blood is antibody B. So these things will immediately start a fight if they come into contact with any B blood grouping. So again, antigens on the red blood cell identifying it are going to be A antigen, and antibodies in the plasma are going to be anti-B antibodies. So I will pick a fight with B blood. Group B identifies itself as B antigen. So I am identifying myself as B antigen, and I have anti-A antibodies. So I will definitely pick a fight with A blood group. Group AB has both on their red blood cell. So they have both the B antigen and the A antigen on there. So they can identify themselves as either. And AB also has no antibodies present, but they have both the antigens. On Group O identifies itself as nothing. It is like the UN. I am completely non-fighting here with either side. However, the antibodies that are present, it has anti-A and anti-B. And it has no antigens on it. Blood components. We have whole blood, packed red cells, and plasma. Whole blood consists of red and white blood cells, platelets, electrolytes, plasma, and stable clotting factors. It's all of the blood in one bag. 1 unit equals 500 milliliters of blood. Packed red cells, or packed RBCs, have 80% of the plasma removed. So these things have a lot of the protein factors and a lot of the immunoglobulins and a lot of the immune stuff and the clotting factors all removed out of there. They do, however, have a concentrated version of red blood cells. Plasma. Plasma is the liquid portion of the blood and lymph. It carries nutrients to the body tissues, and wastes are transported for excretion. Administration of blood. You need to be able to recognize the signs and symptoms of an incompatibility reaction or acute immune response. Recognize the signs and symptoms by the body system, what's going to happen in the respiratory, cardiovascular, nervous system, and the renal system, so that you can get ahead of it as fast as you can. Symptoms of a transfusion reaction. In the respiratory, we could not breathe, we could have coughing, difficulty breathing or dyspnea, rowels, tachypnea, fast breathing, or wheezing. Allergic type responses. Cardiovascular, shock, chest pain, hyper or hypotension, bradycardia or tachycardia, and a weak pulse. Nervous system, apprehension, they're going to be shocky, fever, headache, numbness, tingling, sense of impending doom, all the things that we would see in an allergic reaction. Renal, flank pain, concentrated dark urine, and this would be from hemolysis, or breaking down the red blood cells. Musculoskeletal, we may have back pain or abdominal cramping. Gastrointestinal, abdominal cramping or pain, diarrhea, it may be bloody, nausea and vomiting. In the integument, or the skin, we may have diaphoresis, urticaria or hives, itching and rash, edema, cyanosis, and facial flushing. Please be able to identify these. Makeup of bodily fluids. The average human has about 5 liters of blood in circulation. Blood is a mixture of cells and plasma. Cellular elements of these are going to be erythrocytes, or red blood cells, leukocytes, or white blood cells, and platelets. In the formed elements is where all of these floating parts are located. So all of our cellular area, white blood cells, red blood cells, platelets, are all in this formed elements. The fluid, the plasma, is down here. Intercellular fluid, out of the 60% of the fluid, this is a cross-section of all the rest of the fluid. The 60% of the fluid, 45% of this is intracellular. And 15% of this is extracellular, so this is outside of the cell. Interstitial fluid is 10.5%, and then the plasma, last but not least, is right here at 4.5%. IV therapy. 2 indications for IV therapy are the replacement of fluids and to provide a route for drug administration. 2 major classes of IV solutions, which we talked about these a little bit in the last chapter, are colloids and crystalloids. So again, compounds that are colloids are of high molecular weight, usually proteins which do not readily diffuse across the cell membrane. Osmotic pressure means that they are essentially thicker, which means they tend to attract water into the intravascular space. Examples of colloidal solutions are going to be things like plasma protein or albumin, dextran, head of starch, and mannitol. Mannitol is used for intracranial pressure. It's an osmotic diuretic. We put it on board, it shrinks the cells in the head because it draws water to it. Makes the cells smaller. Crystalloids, things like Hartmann solution, normal saline, dextrose 5% in water, all are crystalloid solutions. That's what we mostly use in EMS. They're classified according to their tonicity that's related to plasma. So are we thicker or thinner than plasma? Or the same consistency as plasma? In the case of normal saline lactated ringers, they are isotonic solutions. Tonicity. We have 3 tonicity. Isotonic, again, no net movement. And we had talked about this in the last chapter. A hypertonic solution. If I introduce a hypertonic solution here, it's going to be thicker than what is surrounding, so it's going to pull fluid towards it. And then a hypotonic solution, If I introduce a hypotonic solution here, it is thinner than what it's going into, so it's going to rush into inside of the cell. Now, whenever we talked about this in A&P, one of the things that we saw was that if it's like water hypotonic solution, it may actually burst the cell. It may burst the cell membrane trying to balance that tonicity, if you will. IV solution tables. We have multiple solutions on this table. And normal physiology tonicity is about 280 to 310. So the closer that we are to this right here, the more isotonic we are. That means things that are underneath that, like dextrose 5% water, are just a little bit hypotonic, which means they are a little thinner than what we're putting them in. And 10% dextrose injection is a little hypertonic. It has a tonicity of about 505. Sodium chloride, 308, definitely within our range. 5% dextrose and 1/4 normal saline, a little hypertonic, a little outside of the 310. Just a little though, not much. 5% dextrose and half normal saline, a little hypertonic again, a little over 310. 5% dextrose and 9 and normal saline. So the more parts that we add to this, 10% dextrose and normal saline, the higher tonicity we get, or the thicker the solution is. And the higher tonicity is, the greater chance it has of actually pulling fluid towards it, or being hypertonic. Antihyperlipidemic agents. The book goes over things that would be concerning with the blood, including high concentrations of LDLs and HDLs and or what we would consider cholesterol. So it gives some criteria to look at. Status of total cholesterol. Desirable is probably going to be less than 200. A borderline high would be 200 to 239. And a high cholesterol level would be greater than 240. Now, LDL, this is the low-density lipids. This is considered our bad cholesterol. Optimal, whenever we break this down, we want the LDL under 100 milligrams per deciliter. Near optimal would be 100 to 129, and high risk for you making a clot or atherosclerosis would be somewhere around 160, 189, and super high risk, you're fixing to have a heart attack, would be 190 or greater. Status of HDL, high risk, less than 40. Average, 40 to 50. Low risk would be greater than 60. Statins and how they work. Now, statins are pretty complex. They are following compounds of structural analogs of HMG CoA. Now, what that is hydroxyl methylgluteryl coenzyme A. And it's a precursor to the development of cholesterol. These analogs are cause partial inhibition of the enzyme and impair the synthesis of the precursors of cholesterol. So the drug action provides both an increased catabolic, I'm going to break it down and bust it up, rate of LDL, and the liver's extraction, let's get it out of here, of LDL precursors from the blood. And whenever we take a look at it, in the formation of cholesterol, now this is a lot more complex than we're ever going to go into, but it's the only picture that I could really find, that this right here and the reductase is where statins work. So if we stop the cholesterol before it starts, we don't get all of this chain here, or we get a decreased amount of this chain. That reduces the amount of overall cholesterol in the system, and more specifically the bad cholesterol, or the LDL. So these are all HMG CoA reductase inhibitors. So these all work off of that pathway that I just showed you. So very simply, there is no EMS considerations on any of these drugs, but you will see a lot of patients that you actually run on these drugs. So Lipitor, it's an antihyperlipidemic mechanism of action. HMG CoA reductase inhibitor inhibits rate-limiting step in cholesterol biosynthesis by competitively inhibiting HMG coenzyme A reductase. Indications, this along with diet to reduce the total LDL cholesterol levels. Contraindications, since the liver has a lot to do with this, is going to be active liver disease, any kind of pregnancy. This is going to be a bad thing for pregnancy. Examples of this, we have a pretty good metabolization and a development of fat in pregnancy. Well, if this is reducing the amount of cholesterol that's available, this could be bad, and or lactation. Mammary glands producing colostrum and things like that, this would all be hampered. Daily dosage, 10 milligrams. Like I said, there's no EMS consideration on this, and then you can go to 10 to 80. So we're going to see variations of dosings on all of these patients here. Cerivistatin or Baycol. Same thing. I'm just going to make a quick overview, so please take a little overview of these. These are HMB-CoA reductase inhibitors. Oral tablet, 0.3 milligrams each evening. Again, active liver, pregnancy, and lactation. EMS considerations, again, there are none, but you're going to see patients taking these. Simvastatin or Lescol. Again, antihyperlipidemic. Works off of the same reductase inhibitor that we've been looking at in the last two slides. This one here doesn't really talk about, you can't use it in active liver disease, so pregnancy and lactation. So this might be something that you could actually use on people in active liver disease. And again, even on this one, there is no EMS considerations. This is not something that we're going to start our patients ever on. Again, the same thing. HMG-CoA reductase busts up the precursors of cholesterol. Indications, the same as it's been for all. This one again is active liver, pregnancy, lactation, or the use in children. The rest of those probably could be utilized in children if you have hypercholesterolemia. And again, route and dose on this changes depending, because it's a different medication. And EMS considerations are none. Pravastatin or Prevacol, same. What I mean by that is it works off of the same thing. Active liver disease, pregnancy, lactation, use in children. Variation dosing, daily and at bedtime, no EMS considerations. Again, the indications, adjunct to diet and reduce of LDL cholesterols. Simvastatin, same thing. These are all going to be the same as far as HMG-CoA reductase inhibitors, adjunct to diet, LDL, active liver disease, pregnancy, lactation, use in children on this one, and variation in dosing. Again, no EMS consideration. So, but your patients are going to be running on these all the time. The general overall gist of these medications is we think that LDLs create atherosclerotic plaques or assist in the buildup of atherosclerotic plaques in the coronary artery. So by giving the patient this, it decreases the amount of cholesterol and it decreases the amount of LDL or bad cholesterols in the system. In conclusion, administering blood and blood products can be life-saving. However, if done properly, it can also become deadly. If done improperly, it can also become deadly. It is very important that the EMS professional understand the rationale behind giving a particular IV solution. There are many individuals taking medications to help lower cholesterol levels. EMS professionals should become familiar with each of these drugs so that they can better understand the disease process of coronary artery disease and hypercholesterolemia. References: this was taken from Beck Pharmacology for EMS Providers, pages 21 through 27, and Bledsoe's Pre-Hospital Emergency Pharmacology, 7th edition. Also, Trevor Anthony, Basic and Clinical Pharmacology, Laying Basic Science by McGraw-Hill. Slide 21 was taken from Wikimedia. If you have any questions concerning this chapter, please feel free to give me a call. My name is Roy Smith, smith@imsa.net, or 405-219-7613. Thank you.